putting more ideas and as we're learning more from the teams. So bear with us and please provide feedback. I am joined by my other colleagues, which I do see, Hannah De Hoyes from my team, who will be assisting us throughout and helping me to remember anything that I might have forgot. So this is being recorded and we will post the recording afterwards. Hannah, is there anything I'm forgetting to say or do?
Not that I recall. I apologize. I had just finished walking my dog, so I had to rush in.
It's all good. You're here. That's what's important. All right. So with that being said, the objectives for today is knowledge, improve the knowledge and usefulness of the toolkit that we prepared on our website, and to listen to our teammates, or I'd rather say, I don't even know, Christina, you've been with us for so long, it feels like family mates for Toolkit and ideas how to expand your ED expansion work, even if you just start thinking about this. So this is all great. So with that, my first step would be, so I've been hearing about this toolkit, where do I find it? So I took very simple approach, but I'm hoping this is going to be helpful to the folks. Step number one, go to Google, type in PMHCA toolkit. The first thing what popped up for me, now you might have a different view on your end, but the first thing that pops up for me is this sign with a little bear, and it says EMACH Improvement Center, and you kind of click on it. So here I circled this for you. This is how you find the first step. The second step, actually, when you click on it, this is what pops up. So you might get confused as to where do I click? Where do I go next? Well, you go into this highlighted areas as Technical Assistant Toolkit. This is in the first sentence of the text, which I did do. So, and you're probably going to recognize, you'll see this picture. The next step will be to actually seeing the toolkit, and I'm not sure if you guys are able to see what I'm seeing, but it's my Zoom is covering a little bit.
I shared the link.
Great. It says step 1, identifying ED opportunities for your team. So the goals here is to understand what the EDs are already doing and understand what matters in EDs the most. And that gives you where do I start? Where to begin? How do I even begin frame this work, right? So I do encourage, there are a number of things to do on the step 1 for teams who are just thinking about the work, or maybe begin to kind of explore the first steps. Do please review the ED care path. It kind of helps you learn about the ED care flow. And then we did provide ideas of how the ways that PMHCAs can support EDs. They are by no means inclusive. There are so many other ideas, but this is what we gathered through participating with a number of our teams. We had 7 teams who worked with us during the first year that identified the opportunities. And the EDs who participated with us with collaborative in the EIC side that help us identify those opportunities. Now, I've tried this link, guys. If you are the person who wants to know more, if you looked at this and say, okay, I really need to learn more about EDs, I really know nothing, I strongly suggest, there's a link I included here that for some reason, even though I click on it, it does not take me there. However, I did copy and paste this link into my browser, and let me bring this up. It did, let's see, when you click on the link, look like this. Can you guys see it says EIC at the top? It says collaborative sessions.
Yes.
Okay, so this is the link that takes you to our recorded collaborative that we had over 70 EDs participate in last year. And that collaborative was called ED Stop Suicide QI Collaborative. What I suggest is for those who are really interested to get to know the ED space is scroll a little bit lower and find Fireside Chats. Here you will find actually the videos and slides of a variety of mental health related topics that have ED experts discussing, providing ideas to other EDs that one could listen in and gauge the need, okay? And it also will provide folks with that background as to what questions do I even want to ask if I have an AD provider in my advisory group, right? So sometimes we just how to say, don't have that clinicians or workflow ideas. I believe these videos are a very great start to begin thinking of those opportunities in the ED. Again, I included the link, however, it didn't work in my PowerPoint, so I put it in the browser, and it did give me this site. We will find maybe an easier way to include it in our follow-up
I
email
put in
to
the
everyone.
chat.
Thank you, Hannah. Wonderful. All right, so I know that Christina has joined some of the collaborative groups in the past when we had a collaborative in place. And is there something like a nuggets of wisdom, Christina, you'd like to share with the group?
One of the main things, can you guys hear me?
Yeah, we can hear you.
Okay. One of the main things that was really helpful for me is even though our project is not associated with a hospital, we're actually associated with a university. There were a lot of things that I was like, oh, I don't think this applies to us. I don't think this applies. But if you're a part of a hospital, I think more things will apply to you. If you're like us and you're not a part of a hospital, like stick with it, because there are really key pieces that can still be really beneficial, even if your program is not housed under like a hospital entity. That was one of the main things for me, because I remember the very first meeting that I went to, I went back and I told my team, I was like, I don't know if that's for us. And then I went to the next one and the next one and the next one, and it was like, oh, this is for us. There are still really helpful, usable things that are a part of this. So that's one thing that I would say, just as kind of that outlier of not being part of a hospital group. There's still very usable, helpful things.
Thank you for that. All right, and the step number 2 in the toolkit, we've identified as understanding your team's level of readiness, and meaning readiness to engage with EDs. And the framework we use for this, and might be some of you familiar with this, but is the systems, right? And we have the 4 S's: the space, the stuff, and the staff. So this is a framework been used by many organizations in the past, but something that is simple, kind of easy to put into the actions. But the stuff is the tools and resources you have available to you. Like what are your strengths, right? What is your PMHCAs already doing? That could be, in addition, it could be added in from the ED lenses that maybe not of a big of a lift. Maybe some will start with something small. And then staff, do you have staff who can support this work, right? It gets very complicated as we know. There's a lot of turnover in our healthcare systems, and there's not enough folks who can help with this work. So that is always should be on the back of our minds. And then space. So do we have, and that could be looked from this perspective, could be looked, do we have little space for people to work, right? Or do we have the structures, meaning advisors on our advisory committees who can help us with this work? And if the answer is we don't, please contact us. We can actually connect with someone in your state who can open a number of ED doors for you. And then of course systems, right? How do our system connect in our logistics, in our workings, right, can connect with other systems, and it's all systems within the systems, very interchangeable, but then understanding how the collaboration can take place. All right, and with that, I'd like to welcome Christina Brent. She is Christina, and I keep forgetting, you're now director, correct?
Yes, I'm the clinical director for the Oklahoma team.
Thank you. And I'm going to stop sharing and let you share. Does that sound like a plan, or do
That
you
sounds
need me
good.
to? Sounds good.
No, you're
Okay.
good. I can share.
Okay. Stop sharing.
Can you see my first slide?
Yes.
Yes,
Okay.
we can see.
Great. Okay. So I am Christina Brent. I'm the clinical director for the Oklahoma Child and Adolescent Psychiatry and Mental Health Access Program, or OKCAP-MAP for short. So today I'm going to speak on OKCAP-MAP, how we came to be, and the reason we felt that this type of program was imperative in helping meet pediatric mental health needs in the state of Oklahoma. I'll also speak on how we've used the EIIC toolkit to assist with a big provider education resource update that we are currently working on. So the need, increased access to child psychiatry and mental health services. Hold on, let me correct my notes. Okay, so study after study and data point after data point has indicated that Oklahoma has a large pediatric mental health need. So in 2001, Oklahoma ranked 46th for youth with a higher prevalence of mental illness and 33rd with access to care. So we are one of those states that unfortunately are usually at the wrong end of all of the statistics that have to do with children's health, mental health, just in general, mental health services, education, all of those. We're at the wrong end of all of those statistics, unfortunately. So our youth suicide rate had increased by 103%, has increased by 103% since 2007, compared to a 42% increase nationally. And it is the second leading cause of death in ages 10 to 24 in our state. And we also looked at social determinants of health and how those have had a factor in these outcomes for our state. So our process started in 2021. So I want to look at some of the stats that were specific to that. And I'll do that on one of the next slides. So we have a ton of pieces of evidence that we could have used. We just pulled a few. We zeroed in on these for the sake of again, just highlighting a few. So in order to help fill that gap, a group including Tri-West, Healthy Minds Policy Institute, and the Oklahoma Department of Mental Health and Substance Abuse Services, and Oklahoma State University Center for Health Sciences applied for HRSA funding. But some of that data that came before. So the Oklahoma Department of Mental Health and Substance Abuse Services conducted their youth behavior risk survey in 2021, which was very convenient timing for us. So a little context for that, the Oklahoma Youth Risk Behavior Survey, or the YRBS, is part of the larger Youth Risk Behavior Surveillance System, or YRBSS, which includes a national school-based survey conducted by the Center for Disease Control, as well as state, territorial, tribal, and local surveys conducted by state, territorial, and local education and health agencies and tribal governments. The Youth Risk Behavior Surveillance System monitors 6 types of health risk behaviors that contribute to the leading causes of death and disability among youth and adults, including behaviors that contribute to unintentional injuries or violence. Sexual behaviors that contribute to unintended pregnancy and sexually transmitted diseases, including HIV infection, alcohol and other drug use, tobacco use, unhealthy dietary behaviors, and inadequate physical activity. The YRBSS also measures the prevalence of obesity and asthma among youth and young adults. And the Oklahoma Youth Risk Behavior Survey is a randomized statewide survey. The data is representative of public school students, grade 9 through 12 in the state of Oklahoma. 50 schools from around the state are randomly selected to participate in the survey, and statewide surveys are administered using the established CDC protocol and in partnership with the CDC in the spring of odd numbered years. I know that's a lot of context. I just wanted to, since this is something unique to our state, I just kind of wanted to share some of that. So what we did with this 2021 information was pull out those significant factors related to mental health, specifically suicidality, which you'll see here. So feelings of sad or hopelessness, suicidal ideation, a plan. So kiddos who have formulated a plan, kiddos who have attempted, or those who have sustained injury or death as a result. And when we broke those down, we were able to see that, so percentages, I think I got my little dot right here. So almost 45% of the youth involved in the survey said that they had experienced sadness or hopelessness. Over 20%, I think that's like 22, 23% had experienced suicidal ideation. Almost 20% had come up with a plan. 10% had attempted, and about 2 to 3% had sustained injury or death. So really, really sad numbers for our state. And then we also looked at the national average for those under the age of 18 who presented to an emergency room for a psych-related situation, and we averaged the monthly encounters by year to see the overall year-over-year trend of crises presenting to the ER. And then one of the things, once we had all of this really disturbing data, we said, what can we do about it? Starting the conversation was one of the things. So who's responsible for starting the conversation? So the text on this slide is usually a little bit small to see on a screen. So I'm hoping that I played around with it. I'm hoping it's a little easier to see.
We can see.
Okay, great. So what it shows is that when asked who should start a conversation about a child's mental health during a primary care visit, this survey had showed that families replied with the following. So 36% of families said, well, the doctor needs to be the one to bring it up. If the doctor doesn't bring it up, it's not part of the appointment. We're not going to discuss it. 25% of the families said that it should be the parent or the guardian. 15% said either or. Doctor, guardian. 12% said anyone concerned. It doesn't matter who. If there's a concern, then anyone can start the conversation. 8% said the nurse. So I'm guessing maybe through some sort of triage, or you know how they'll usually answer all of the questions with the nurse before the doctor ever enters the room. It should be included in those questions from the nurse. 8% felt that way. What this tells us is that, sorry, my notes are not showing. Okay, so what this tells us is that at least 36% of families will more than likely not start a conversation in the primary care doctor's appointment, will not start the conversation about their child's mental health. So as mentioned earlier, in order to help fill this gap, and that's what our little tag phrases, like I think so many of the other programs, is bridging the gap. So that group, including TriWest, Healthy Minds, ODMH, the Oklahoma Department of Mental Health and Substance Abuse Services, and Oklahoma State University Center for Health Sciences applied for HRSA funding. And I love this. We pulled this directly from HRSA materials. The mental health need for children and adolescents is rising across the nation. And HRSA is trying to help this need by helping support states to start child psychiatry access programs. As most, if not all of you know, this process started in 2003 with a pilot program in Massachusetts and building to the official incorporation of NCPAP in 2014. So more and more states began adding CPAPs, and in 2018, HRSA had provided federal funding for some states, and then they expanded to the majority of the nation when they added additional grants in 2021. And that was Oklahoma. So we are in green. We were a recipient of HRSA's funding in 2021. And with this funding, OKCAPMAP was formed with the mission of provider to provider support. But what's been reinforced to us since 2001, since this whole project started for us, was the need to expand beyond the primary care setting. So a little more context. In 2001, the OKCAPMAP team began by creating a statewide advisory committee. It's now our advisory board with subcommittees, as well as sending out a provider needs assessment. And I think slides will be shared out. And so there's actually a link right down here. That is our providers needs assessment. If anyone is interested in seeing that, that link it still takes you somewhere with that survey. The participants that we included.
Yes, it does. I was going to say, I used it
Yeah.
just recently for one of
Yes.
the examples for our providers evaluation.
Yeah.
So thank you so much. Link does work. So appreciate
Yes,
it.
it's still an active link. We never discontinued it, which has been really helpful for me whenever I need to go back and see what those questions were. But this is a breakdown of the providers who participated in our needs assessment survey, breakdown by training. We had just under 70% were allopathic, just under 30% were osteopathic, just under 2% were registered nurses, and we had a PA, some PAs in there as well. And then breaking down by specialty, just over half were pediatricians, almost 32% were family medicine, almost 3% internal medicine, and then 15.5% were other specialties. This is a breakdown of those participants by location, our little heat map. And actually, because of this, it caused us to put a big shift in our focus. We were originally planning to state, but so this is the Tulsa metro area, and then this is the Oklahoma City metro area, and those counties are 2 of only 4 counties out of 77 counties in our state that are not underserved. So we have 73 counties in our state that are considered underserved counties, and all but, I want to say 12, if I remember the numbers correctly, all but 12, 7, 12, I don't remember. The vast majority of the counties in our state are also rural. So we've got rural states or rural counties in our state and primarily underserved counties in our state. So we're like, we can't do regions. We've got to launch statewide. But the feedback that we got from our provider needs assessment survey said that almost 90% said we need help with referral assistance. Almost 80% said we need help with psychiatric consultation. We need help with proper prescribing. We need help with medication management. A little over 45% said education for the providers, and about 30% said education for additional staff. So techs, nurses, whoever else might have a hand in a direct service for an individual in their care. And some of the qualitative themes that we pulled out from the provider needs assessment survey, which also included 20 primary care provider interviews, was medication consultation beyond an initial evaluation, developmental and complex diagnosis education, referral assistance, medication management post-discharge. And then one of the things we asked was that magic wand question. If you could wave a magic wand and wake up tomorrow and have everything that you need within your clinic or your entity, what would that be? And they said in-house psychiatry, counseling, and case management. So our challenges, because every state has its challenges, the main ones that we picked out from all of this assessing and surveying and questioning and interviewing is access, services, understanding, and complexity. We are very rural. I know there are a lot of states that are very rural. We are one of them. And in our rural areas, there is very little access. Either there is no one there, there is one person there, and so the wait is a year or more in some cases, or transportation barriers. It's so far away to get to the closest service provider. And then helping the providers know how to have those hard conversations with the families around limited resources and around the need itself. So with all of this data and all of this building and next step planning, our direction put focus on these three components: consultation, education, and referral. So mental health education, mental health referral assistance, and psychiatry and mental health consultation support services. This link, again, it is active. It takes you to an actual place. This is our provider education link, and this is actually a little snapshot of some of what you would see on that page of our website. So we have a monthly newsletter that goes out. We do lunch and learns. Our lunch and learns we try to take to those rural areas across the state. We try to do about 6 a year. We host a conference every spring. It's a one-day conference. And then we also partner with Project Echo. For those of you who are familiar with Project Echo, use that as a resource. It is amazing. If your state does not have Project Echo, then I would suggest looking into it because it's fantastic. And then we have 2 of our Echoes are specifically focused on pediatric mental health and infant mental health. And our psychiatrists that we have with OK CatMap are actually hubs and facilitators for those 2 children's Echoes. So those things are able to work hand in hand really well. And every piece of education that we like formal, like training, learning style education is available for CME is attached to a CME or CEU. So continuing medical education or continuing education units if you're like master's, bachelor's level provider. And then we have online learning modules. So these are the ones that we currently have. We're also working on a suicide prevention learning module, but we have not had that one completed yet, but that will be one that gets added in within the next month or so. They're an hour long. It's asynchronous learning, so you go at your own pace. But again, it's worth an hour of continuing education. And if you are a registered provider with us, then all of the asynchronous learning modules, lunch and learns, all of those are free access. If the provider is not registered with us, the asynchronous learning modules, I think, are like $25 to access. And we have had some people who have done that, from a lot of people in California. And then this is just like a screenshot of what our first module was, our anxiety module. This is a screenshot of the beginning of that. They're interactive, so you can kind of see down here, like click to flip. And then they have kind of like track your learning, a quiz that'll go after every few sections of it. So it's not like you just press play on a video and can drown out kind of thing. It's interactive. We've had really good feedback from this style for our learning modules. And we do partner with the continuing medical education department for OSU. One of the main ways that we track our provider access to education is through this partnership with CME. They track a provider's credential and specialty based on how the provider registers with CME. So if someone wants to access any of our learning and get the CME or the CEU for it, they have an extra step of registering with OSU CME, and then CME tracks and houses all of the records for that. And we meet regularly with CME to review data related to the OKCapMap specific learning. That's going to include the annual conference that we do, our lunch and learns, which are hybrid and online via Zoom, so in person and online, and then our asynchronous learning modules. Those are the things that CME helps us track. And then for things that fall outside of that formal learning, every single one of our consultations has an education component built in, and we track that through our documentation and record system, which we use Salesforce Lightning for that. But we also use Google Analytics for tracking our website traffic. So we're able to see number of views on a given page, which links were clicked, and other helpful data points. And we can filter by a specific area of the website or a specific date range or something else. So for example, this second image, excuse me, shows a snapshot of views specific to our provider education, family resources, and provider resource pages for just our first quarter of this year. So we're able to see how many views. I pulled that out, but you can also see, we can see views, unique users. So we've had almost 2,000 views in that quarter. Or that time frame. I can't remember what the time frame was for the background image. But of almost 2,717 of them were unique users. So 717 individual people viewed 2,000 things. Average views per user, engagement time, and then total like click events. So Google Analytics does a really great breakdown of all of those little nuanced pieces. And one of our main focuses for this year is increasing accessibility with regard to provider education. So we're revamping our website as well as updating a lot of our digital resources. And one of those is it's the Oklahoma Pediatric Psychotropic Medication Resource Guide. We really like long, difficult names in our state so that we can have really long, difficult acronyms. It's just something that I think we should be known for. But this was originally...
That's a good one. That's a good one.
This was originally developed in late 2019, early 20. And we're in the early stages of updating it. And for the updates, we're putting together a new task force, some of the same folks as before and some new. We're completing an updated lit review, and we're pulling information regarding topic areas from consultation data. And we will also be adding in new, specifically a new resource section. And that QR code, if you scan that takes you to a digital PDF, or we've got a link down here. But a digital PDF version of this, it is free to access. And we give this as a resource in a lot of our consultations that we do. And then, so we've been able to use the toolkit as a guide for some of these updates that we're wanting to make. So as part of our review process, we've been digging back into the different toolkits that have been beneficial to us. And in reviewing the EIC ED toolkit, we found helpful resources in these areas specifically. And we're going to do an even deeper dive to see how we might be able to incorporate or use some of this as a model as we continue our revamp of our psychotropic medication resource guide. And then the link at the bottom is the link to the ED toolkit. And one thing that I want to do is just like a quick little walkthrough of our resource guide. So I'm hoping that if I minimize, let me get over there. If I minimize this screen, do you see a new screen now?
No, it's the same screen.
Okay, let me.
With little feet on one side and
okay.
Oklahoma Pediatric. Now
Let
you stop sharing.
Yeah. I am gonna share this. You see something different now?
Yeah, it says references.
Okay. So if you scan that QR, if you go to the web link, like I said, it takes you to a digital PDF of this. And everything is in here. So background and purpose of why this was developed, lots of data, statistics, more sad information about our state, references for where each section's information came from, the task force that was developed. So Oklahoma State University, the University of Oklahoma, they made up the core team. And then so lots of experts in the field were involved. And then it does this breakdown within the table of contents. So if we're looking at treatment of preschool birth to 5, here were the main diagnoses that we're focused on for the first version of this. So one of the things that we're doing in our revamp is we're looking at specifically with regard to the consultations that we've done through OKCapMap. Are there any new areas where we need to focus? Are there areas where we're doing consultation that are not covered in the current version of the resource guide? And if so, we're going to add that section. Same thing with age group 5 to 17. We're also looking at changing the way the ages are broken down to have them actually match the way HRSA breaks down the ages. So 0 to 3, 4 to 6, 7 to 11, 12 to whatever the next one is, I don't remember. And then I think 12 to maybe 12 to 18. I don't remember. And then the 18 to 21. If I didn't write it down, it's not coming to me right now. But again, looking at those specific age breakdowns and what are the themes, the common things that we're seeing through our consultation that maybe was missing from the first version of this resource, and making sure that that is added in. So one of the things that I want to show also is, I'm actually going to go over here to anxiety. So each section starts with these clinical pearls, just kind of that like general overarching information. And then it goes into rating scales that can be used when we're considering anxiety. And so one of the things that we're going to do with our revamp is, are there additional rating scales or updated rating scales? Like basically, are these still best practice rating scales? If there's something new, we want to update that. If they are, is there a new version? Is there? So all of those kinds of pieces are tying into the revamp. And so a lot of those toolkits that have been put out, that's where we're using some of that cross-reference to see. And then we've got the treatment approach. And then you'll see references. So each section is built like that and will continue to be built like that. But one thing that we're going to add is a common resources section. So if we know that we're working with, if we're looking at this age group with this specific type of diagnosis, here are some common resources that we're providing through consultation. It could be a psychoed resource piece for the provider. It could be a resource that the provider can share with the family. So some of those common resource pieces that we see that we're sharing often through consultation with a given diagnosis or concern is something that will be added into our updated version of the resource guide. And then it just goes down into that next diagnostic area. And we go from there. So I wanted to give just that quick little overview. And then I'm going to go back to my slides for the last couple of pieces and got to. So hold on 1 second. Where did it go? Everything was so quick before.
It will happen. It'll come to you.
Let
I
me.
always struggle with pulling up so anything. It seems to be always be gone. All right, we see the resource guide.
Yes.
Work
Okay.
through. We got it.
So,
Yeah.
a little walkthrough. My last couple of slides. This is who we are. This is an updated flyer that we made just within the past couple of months. And this is how to reach us. So these are our hours, our contact pieces of information. This QR code takes you to our website. And then this is just a little bit of our numbers, which I always love. Excuse me, I always love to share our numbers just to do a little bit of bragging. So as of, when did I finish this? Was it Monday, Anna? As of Monday, we have 391 providers across our state that are registered with us. We've done 547 consultations. We've actually done like 5 more consultations since then. 461 patients, so children in our state, have been supported through our consultation line. We've done 11 lunch and learns. We have a 12th. We've had to reschedule a couple times. Like on the other end, it's had to be rescheduled a couple times. But we'll have our 12th one next month, and we currently have 8 published asynchronous modules. We're working on our 9th. This is our registration breakdown. So we have 392 providers that are registered with us. They represent 220 practices across our state. We have providers registered in 40 of the 77 counties in our state. And part of that could be some of our counties don't actually have a medical provider in that county. And so one of these days we hope to get all 77. But the breakdown of those counties, we have registered providers in 10 urban counties, 30 rural counties, and 36 of those 40 counties are underserved counties. And then this is me.
Thank you. I'd like to open the floor to questions, suggestions, ideas. I do want to, before others jump in, and I have your attention, to have the question's been asked in the past, but then I know you guys started thinking about the ED expansion and different streams of implementation. What has been going well with that? Like, you feel you're making some strides? Because again, looking at 3 areas that you pointed out 2 slides before, it's a lot. But what I'm thinking is, what are the nuggets of wisdom we can give to others with ED expansion and starting small, particularly?
Yes. Oh, starting small.
Baby steps. Just give us one before we overwhelm.
I would say network. I would say communicate. That's one of the main things. Even if it's just kind of like, here's who we are and what we're wanting to do, or here's who we are and what we are doing. I think that the communication piece throughout our entire process has been huge, and hugely beneficial in how we have been able to do everything that we've been able to do, especially statewide, because we're in year 3, but we've only been live since October of 22. So October of 2022 was when we started doing the consultations, when we started doing the trainings and the education pieces. So that whole first year of our project, year plus of our project, was communication to build information of what's to come and what we're hoping to accomplish. And then also being able to get feedback of what the need is and where the need is and how we might be able to fit in to bridge that gap. So I think the networking and the communication piece is huge, and it actually just paid off in a really big way for us. There is a hospital system in the western part of our state, which is a big resource desert, the western part of our state, but there's a hospital system there that just yesterday reached out to us. We were reached out to they do not have a psychiatrist. And so we're now in talks with them on how they can utilize us as a psychiatry support for
Wonderful.
the pediatric
Mhm.
piece of their entire
Mhm.
hospital system, including their behavioral health, because so it's a
Right.
hospital system, but then they also have this big community behavioral health component that falls under their umbrella. And so because we've continued to talk and we've continued to market and promote and
Yes.
all of those things, we now have this huge opportunity
That's
to
awesome.
be with, not with, but like partnered with a hospital system to in a part of the state where there's not a lot of options for services. So
Well, that's very encouraging. Thank you for
yeah,
the
so have the
story.
conversations. That's the one piece that I
Yeah.
could say that is a small step. Have the conversations. Ask people if you can be invited to have a seat at the table. Like, oh, hey, I saw where this meeting was scheduled, or this call or conference or whatever was scheduled. Can we come? Can we just listen? Can we? So yeah, just talk. I think would
Awesome.
be that small step that can have a huge impact.
Well, thank you, Christina.
Yeah.
Thank you for coming. We are going to do two things, you guys. As you see on your screen, you see in the evaluation had popped up. Please give us your feedback. We really, really appreciate it. And while the Hannah will keep evaluation up for the next few minutes, are there questions, suggestions? I'm sure there are some clarifications folks wanted to put out there. Please do so.
There's a question in the chat, Anna.
Okay. I do not see it. Do you see it?
You want me to read it?
Yes, please.
Okay, it's for Christina. How do you incorporate the education component to your consultations? Can you elaborate on that process flow?
Yes. So I actually whenever a provider calls for consultation, the person that answers the phone is either myself or our program director, who is also a licensed mental health professional. So the consultation starts with a master's level licensed individual. And so we're able to, on the front end, collect that information of so this is kind of how I started is once we've got like the administrative pieces out of the way, which take like 2 minutes to complete if they're not registered with us already, is what information would be helpful for us to know for this consultation. We started that way because initially we had like a guide that we tried to follow, but what we realized is not everything that we might want to ask is impertinent to the situation at hand. And so by just kind of giving this open-ended question of what do we need to know in order to help you, the providers are really great about giving us those pieces. And if they're like, I don't know what would be helpful, I've never called the consultation line before, then we just give them a brief little piece of information about how the consultations typically go. And we follow their lead and we go at their pace. So if they're in a hurry and they have a short amount of time, we might do less education. If they're like, oh, I'm done with clients or I'm done with patients for the day, we can take as much time as it takes. Then we know we've got more of an opportunity for that education. So as they start sharing information about the patient with us, we start to ask those questions of, did you make this diagnosis, or was this diagnosis made outside of your setting? And they might be like, well, we've got them referred for testing, but the testing hasn't happened yet. So this is like until we get the formal testing, this is like the diagnosis we're working with, we think we're working with. And so we're able to provide pieces of information around that. And one of the big things where that education comes in is screening. So you're reporting a lot of anxiety symptoms or a lot of depression symptoms with this individual. What screening have you done? Have you done an anxiety screener? Have you done a depression screener? Have you done a trauma screener? That's one of the main pieces of education that we provide is trauma looks like a lot of different things. So if we're talking with a kiddo who has, it's unknown if there's a trauma history, and we're looking at some big ticket items like ADHD, oppositional defiance, depression, anxiety, it's like, this could all be trauma. And so let's get that trauma screener out of the way. And here's why, because if there's trauma, that's going to impact how we treat the symptoms that look like all these other things. If there's not trauma, that's going to impact what all these symptoms are presenting as. And so being able to have those small but impactful education moments in the consultation, they might be like, oh, I've never screened for that before. What's a good screener? And being able to share those pieces of information has been really, really helpful. And we get a lot of great feedback from the providers, because then the next time that they'll call, they'll say, I already did these screeners and now here's where we are. And so being able to see even the growth in that has been huge. But then also there's an education piece on resource options. So the part of the state that you live in is fantastic, because you're in Oklahoma County and that's a big urban area and we're going to have a lot of options. Or you are in the far northeast corner of the state where there's not a lot of opportunities. So we're going to have to maximize what's available geographically versus what might have to be done virtually. And so being able to have those types of education pieces are helpful also. I feel like I might have gone around that question, but was that helpful? Okay.
We got a yes. Thank you. All right, folks, we have 8 minutes. Other questions or suggestions? And if not, we certainly can finish early.
And I will jump in real quick and say
Yes,
the
please.
average time for our consultations is about 15 minutes, give or take. So we really try to capitalize on the time. We've had providers who've been like, I have 5 minutes because I am overbooked and I'm behind schedule. And so that's where, again, we follow that lead. So if we have an opportunity to like shoehorn in an extra piece of education, we're going to do it. But we also, every single consultation, we provide an email summary same day. Most of the time it's same day. If it's the end of the day, it might be the next morning, but within well under 24 hours, they're going to have an email summary of what we discussed and what the considerations are that were provided by the LMHP or the psychiatrist. That also gives us an opportunity for education. Here's that resource that I said I was going to share with you. Here's the reason I'm sharing it with you. And here's how it can be used by you or the family or whatever it might be. So being able to provide that email summary at the end of every consultation is also an opportunity for education.
That's a great point, actually. And I bet they appreciate that, because that is information written and as a follow-up, and often we don't remember what we've been told, but this written, and then it opens up the continuation of that relationship, right? They have your email.
Yes,
I can reply to and say, oh, I thought of something else.
Yes, and it also, we've heard feedback from a lot of providers, especially when we have information and supports for the family in that email. The provider will just print the email and give it to the family. Excuse me, my coffee is like, but,
been there, done that.
Yeah.
So it makes it easier for them to
get
to it.
Anything that we don't have a digital version of, it's not a digital version, I'm sorry, anything we don't have a link for, we have an attachment for. Sometimes we have both, like we attached a copy, but also here's a link. So.
Christina, have you been tracking how many people actually followed up to that email that you send out at all? I wonder. Like follow up, like got back to you and say, oh, I forgot something, or this was helpful, or do you guys keep track of it?
Yes. So if they respond and they're like, oh, here, like, did a follow-up with them 2 weeks later, here's this and this and this. So we would add that in as a new note. It's not uncommon where I will copy an email and paste and create a new note, because it might be that they're asking for resources in a different area because they're about to move, kind of thing. And so I will copy whatever information the provider gave, because everything we do is de-identified also.
So this is an additional service you provide on
Yeah.
top of the consultation.
Yeah, so it just becomes a new, like a
awesome
consultation too on the same patient. So how do we handle PHI when it comes to these emails? Do you just reference a consult number? So one of the things that we did is we worked with the university's IRB, Internal Review Board, to make sure that we were doing things that were HIPAA compliant. When we have a provider call with a new patient, we ask them, what is the medical record number or the chart number that you use to de-identify this patient? And then that is the number that we put in our system, so that if we're going to do a follow-up consultation, we don't have name, we don't have birthday. We ask for, the only demographics that we ask for is age, race, ethnicity, and age range. And gender. Sorry, thank you. Someone in the background just said gender. And gender. And we do gender identity. So we have, like, our system will let us differentiate if the patient is identifies as transgender male or transgender female. So we track gender identity. And if a provider happens to say a name, we say, oh, actually, I don't need the name or the birthday or any identifying information. We keep everything de-identified in our system. All I need is, let them know.
Okay. We have 2 minutes, folks. Anything else? Well, we will share the slides and we will share the recording, and the slides will have Christina's information. So hopefully Christina will not mind if somebody reaches out and asks questions.
Not at all.
Here you go. All right, with that, we're gonna stop recording. I don't think I have the power. Hannah, can you stop recording? I don't think I have power to stop that.